Yes, ma'am, go ahead.
I welcome you all for Harmony, the sixth episode of this program, the webinar that is organized by FOGSI Endocrinology Committee and ICOG. At the outset, I would like to invite Dr. Parag Biniwale, the chairperson ICOG, to speak a few words.
Thank you. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all for this episode of Harmony, in an initiative which was started this year along with the Endocrine Committee of FOGSI, where we wish to touch upon the very, very basics of reproductive endocrinology, which is actually meant for all the postgraduate students as well as practitioners. I must appreciate the efforts put in by the team behind Harmony, the convener, Dr. Chaitanya Ganpule, chairperson of the FOGSI Endocrinology Committee, Professor Vaishali Forde Nayak, who's one of the key persons behind this, and ably supported by Dr. Manasi Naralkar, Dr. Mansi Sharma, Dr. Madhu Juneja, and Dr. Vinuta. So every time we try and get somebody who's worked in this field and we try and learn the basics of endocrinology from them, I must appreciate that all the 5 episodes which were done so far were really uh, very very high caliber as far as academics is concerned. So I'm sure rest of the programs will also generate so much enthusiasm, and I'm sure this activity will continue next year with Dr. Sheila Mane as the chairperson. On behalf of ICOG, I welcome the speaker, Dr. Chandrika Anand, who's one of the most important parts of the endocrinology committee for all these years. Chandrika, thank you for agreeing to be the speakers today.
Thank you, sir.
And I welcome the chairpersons of today's session, Dr. Nutan Agarwal, who's the ex-professor of OBGYN from AIMS, Delhi. And of course, she's one of the key persons in Gynae Endocrine Society of India. And of course, Dr. Kavita M. Bhatti, who's a professor at head at very prestigious CMC Ludhiana. So I'm sure it's going to be a great learning experience for all of us. My best wishes for the program and happy learning to everyone. Thank you.
Thank you, sir. I would also like to invite Dr. Chaitanya Ganpule, the convener of this series, to say a few words.
Good afternoon, everyone. And on behalf of the FOGSI Endocrinology Committee, I would like to welcome all of you for this webinar series, Harmony, along with ICOG. And I would like to thank Dr. Parag Biniwale, Chairperson, IC Chairman ICOG, for giving us this opportunity, and FOGSI President Dr. Sunita Tandalwadkar and General Secretary General Dr. Suvarna Khadilkar. This is, as sir said, this is the sixth episode, and we are going good, and we hope to continue the same enthusiasm for the next year as well. I would also like to welcome today's speaker, Dr. Chandrika Anand, who is the South Zone Coordinator for Endocrinology Committee as well, and she has done a lot of work in nutrition and PCOS. And today's chairpersons, Dr. Nutan Agarwal and Dr. Kavita Bhatti. Welcome, madam, for this webinar, and thank you for accepting the invitation. Without much ado, I would like Dr. Mansi to take over and start with today's program. Thank you so much.
Thank you, sir. We welcome our chairpersons today, Dr. Nutan Agarwal, ex-professor, Department of OBGY in AIMS, and Dr. Kavita Bhatti, professor and HOD CMC Hospital, Ludhiana. Both of them have a lot of publications and awards to their credit. Welcome, madam. And I would also like to invite our speaker for today, Dr. Chandrika Anand. Madam is the Director, PCOS Center and Chief Consultant at Fortis Hospital, Nagarbhavi, Bangalore, and one of the top 10 gynecologists in South India, as well as a lot of other credentials to her credit. I welcome you, madam, and I hand over to you to commence your talk.
At the outset, I would like to thank Parag Beniwas sir, who is encouraging our committee from a long time, and thanks to ICOG for giving us this wonderful opportunity to talk about different aspects of endocrinology in women's reproductive health. So today I'll be talking about hirsutism. Um, Today I'll be talking about hirsutism. So hirsutism is a very distressing symptom. It is not a disease as such, but then it is so distressing that all of us need to address that like a very big disease, because it has got a lot of physical and social and psychological impacts on the woman. So hirsutism and evaluation and management is my topic. So I'll be going to cover few basics about structure and types of hair and androgens and their effect on the hair growth, and what are the causes of hyperandrogenemia in women, and then how hirsutism is the most important and common feature of hyperandrogenism, and what is the impact and how do we evaluate and manage this patient with hirsutism. And the definition of hirsutism is a medical term that refers to the presence of excessive terminal or coarse or thick hair in the androgen dependent areas of the female body. Now, the commonest pathophysiology causing hirsutism is excess androgen or hyperandrogenemia. This is the strongest clinical sign of androgen excess apart from severe acne, alopecia, and voice change and clitoromegaly. So hirsutism is the strongest sign of the androgen excess. Almost 70 to 80% of women with hirsutism have an identifiable androgen excess disorder, mainly the PCOS, and the second next is the idiopathic hyperandrogenism. Conversely, hirsutism is one of the most frequent clinical manifestations of hyperandrogenism, almost seen in 65 to 75% of such patients. So, this relationship is bidirectional. Women with very high androgens strongly present with hirsutism. Women with hirsutism strongly have or most commonly have high androgens. Now, this hirsutism affects almost around 5 to 10% of women of reproductive age globally. The prevalence can be higher in certain population, with one study noting almost 25% in Iran, 10 to 15% adolescent females in North America. Compared to Caucasians, Asians, including Indians, they've got less body hair. So the prevalence and the cutoff score can be a little lower in Asian women. So overall, the hirsutism is common in India. Almost around 10 to 15% of Indian women present to our outpatient clinics, either to the gynecologist or most often to the dermatologist with hirsutism. Very specific studies report a range of prevalences: 10.5% in Kashmir and 5 to 20 in South Indian studies. Particularly, Kerala has got the highest hirsutism prevalence, and also 17% of young adults. So it varies regionally and also racially. The prevalence of hirsutism varies. Roughly around 70 to 80% of women experiencing androgen excess exhibit hirsutism. Now, let us just briefly visit the anatomy and physiology of hair growth. This is very basic. We need not actually remember this, but at least to understand. So, we are born with almost 50 million hair follicles, and almost 1 lakh to 150 is 1000 is located on the scalp, and rest of the follicles are there all along the skin except the palms and the sole of the feet and lips. The hair structure, it arises from a follicle, and this hair structure or the bulb and the papilla and the matrix, they are very sensitive to the androgen levels. Now, what are the three different types of hair? One is a lanugo. It is a soft hair densely covering the skin of the fetus, which disappears within the first few months of postpartum life. We see a lot of newborn babies. Some people have coarse hair, some people have very fine hair, and then dark hair. But then eventually that will go away. That's called lanugo. Next is a vellus hair, which is soft but larger than lanugo hairs. They're usually non-pigmented and generally very thin in diameter. And then they are light color and barely noticeable hair, which develops on most of the human body during the childhood. Now, what is terminal hair? This is the terminal hair are longer, pigmented, and coarser in texture. Eyebrows, eyelashes, scalp hair, pubic and axillary hair in both sexes, and much of the body and facial hair in men are composed of terminal hair. Now, what happens in hyperandrogenism? The vellus hair, because of the excess androgen, and it has got various receptors in its hair structure, that gets converted to terminal hair. So these are the different locations where the terminal hair is located in women, in addition to all the other areas in men, body and facial hair, is terminal hair. Now, these are some of the differences between vellus and terminal hair. Why am I highlighting this? Because there are a lot of women who complain that they've got unwanted hair on the body or the face, but they wouldn't be having hirsutism. At the same time, we see a lot of women with very thick, coarse hair, which is hirsutism, but then they wouldn't be complaining or bother about it. So before we jump to a diagnosis of hirsutism and then do order so many tests and then try to make a diagnosis of a disease, we should be able to differentiate the vellus and the terminal hair. As I told, this is very fine and short and colorless and lightly pigmented, whereas this is thick, long and heavily pigmented. And vellus hair covers most of the body, whereas terminal hair has got specific areas, as I told you. Now the functions are that it regulates the body temperature and evaporate the sweat, and then this along with the this function, the terminal hair protects the body from bacteria and dirt and helps regulate body temperature. And these are some of the this vellus hair generally they are not under the influence of hormones, whereas terminal hair is strongly influenced by the hormones. Now there are three different phases of hair growth, that is anagen, catagen and telogen. This happens in a cycle in all human beings. So the active growth phase or the anagen, where the hair grows in its length and thickness, generally lasts around 2 to 6 to 8 years. And then there is a transition phase of catagen, where apoptosis happens, and then with the hair stops growing and the hair bud will shrink. Whereas telogen phase is in the resting phase, where the hair is resting and then it is shed and a new hair will displace it. Now, why should we worry about this different phase of hair growth? Because the anagen is prolonged in hirsutism under the influence of excess androgen. So, hair growth disorders of clinical significance manifest as the undesired changes to this follicular cycle. Prolongation of the hair growth phase occurs, as well as vellus hair getting transformed to terminal hair results in hirsutism. Conversely, a reduction in the anagen phase, that is, almost 2 to 8 years, the hair has to stay. If it shortens, then there can be a significant hair loss. Now, what is the effect of androgens and hair growth? So, the growth of sexual hair is primarily influenced by the presence of androgens. Prior to puberty, vellus hair appear as small, straight, and light colored. Upon the onset of puberty and subsequent rise in the androgen levels, the vellus follicles in the pubic axillary areas of both the girls and boys often transform into terminal hairs, which are larger and thicker and a curlier texture. Whereas in the other body regions, as the forehead and cheeks, the impact of androgen takes a different form. Here, the androgen leads to enlargement of sebaceous glands, so that is why in the puberty, most of the adolescents are acne prone because of excess of sebum secretion. So, the precise reasons why exactly the hair grows in one area, and the hair does not grow in the other area under the influence of androgen still is very unclear. This suggests that the androgens exhibit paradoxically distinct effects on the human hair follicles based on the location within the body. Now, what is the source of testosterone in females? So, all the while I've been talking that hirsutism is caused most often, almost 70 to 80% is because of excess androgen or hyperandrogenemia. So, let us learn what is the source of testosterone in females. The major testosterone, the most active form of androgen is testosterone. So, where does this come from? Now, one is the adrenal source, the other is the ovarian source. Adrenal glands contribute around 25%, ovary, the thecal cells contribute around 25%, whereas around 50% is converted by the androsterone, the androstenedione, which gets converted to testosterone. Now, dihydroepiandrostenedione sulfate is the only source is adrenal cortex. Now, this androstenedione, DHEA and DHEAS, all these are prohormones, that is, which they eventually get converted to testosterone. The testosterone, the active form is dihydrotestosterone by the enzyme 5-alpha reductase. Now, why are we talking about all this? Because the anti-androgen hormones act on these receptors and the enzymes and then become effective in reducing the androgen levels. Now, what are the causes of hyperandrogenism in women? The most common cause is 65 to 85%. The most common cause is a polycystic ovarian syndrome. We know that it is a very big, growing, complex reproductive endocrinopathy, having metabolic, reproductive, and mental health issues. That is a PCOS, ever increasing decade by decade. The next common cause is idiopathic hyperandrogenism. For there is no reason why the androgen increases. That happens around 15%. Now there are the other rare causes like non-classical adrenal hyperplasia and Hayran syndrome, and very rarely androgen producing tumors. Now, how does this testosterone cause hirsutism? This increased 5-alpha reductase activity converts testosterone to dihydrotestosterone, which is a more potent androgen. This binds to the androgen receptors in the dermal papilla of the cells of the hair follicle. This stimulates the transformation of the vellus hair into terminal hairs, and the follicle enlarges and it prolongs the anagen phase, leading to thicker, darker, and a long-lasting hair. Now, one more point is that the circulating androgen levels may not accurately reflect the local androgen concentration within the pilosebaceous unit. Meaning to say that if the hirsutism is very severe, does not mean that the testosterone levels are very high. Or if the hirsutism is very less, then still the testosterone levels could be moved. So there is a interplay between the circulating androgen levels, local androgen concentrations, and the hair follicle sensitivity to androgens. Now, just we need to, before we diagnose a hirsutism, there is a condition called hypertrichosis. It is a rare, generalized or localized excessive hair growth, which can happen anywhere on the body, not in the area of which we are going to discuss the 9 specific areas. So it can happen anywhere on the body, both in men and women, unlike hirsutism, which is specific to male patterned hair growth in women. So this is not driven by hormones. It can be congenital or acquired. This is sometimes different medications can cause this hypertrichosis. The pathology is it is a conversion of vellus into thicker terminal hair or increased growth phase. Now, why should we be worried about it? Because it can still be a sign of hypothyroidism, anorexia, and other systemic conditions, and very rarely malignant conditions can be associated. Now, once a patient comes to us or to the dermatologist with a hirsutism or a complaint of unwanted hair, so first we need to see whether the complaint is really genuine, because sometimes the unwanted hair won't be as much as they describe, so the hirsutism may not exactly correlate. So there can be objective methods and subjective methods. Objective method is little messy because we need to see how many hair, the number of hair follicles and how thick they are, what is the length, and when they are removed, what is the volume and all that, which is a little messy and inconvenient. Whereas subjective methods like observing the unwanted hair in different parts of the body and face and assigning a score depending on the thickness and length of the terminal hair. This has been found by Ferryman and Galway. They initially proposed 11 areas, particularly which included the lower legs and the forearms, but then which was modified by Hatch et al. In 1981. This is a gold standard system for evaluation of hirsutism. It is scoring 9 out of the 11 areas and assigning them the score of 0 to 3 in each area. Now, all of us as gynecologists, we are aware which are the different areas and how do we score the thickness of the hair. So, score 1, score 2, score 3, and score 4. That is, if it is as thick as a adult male, or if it is thick but not so thick, and then it is just very thin. So, depending on this, we need to score. It's a visual scoring, so we can train our nurses to score it and we can cross check whether they're doing it right. Now, what is the why should we score it? I mean, in the sense, why should we score it? Because the more the score is, as I told you, it does not correlate with the androgen levels. The more the score is, the more distressed is the woman. So we need to manage the patient whether she needs only local treatment or cosmetic measures, or whether she needs anti-androgens, or whether she needs hormonal pills. So for that, we need to score it. And also, once the treatment is given, we can score down, in the sense we can see how much the score is improved, so that it is a prognostic value. So a cutoff value of 8 or above to be applied for white and black women, whereas Far East and Southeast women, this is decreased to 3 and above. Okay, whereas in India the proposed cutoff is 6. Okay, because as I told you, in India, Indian women are less hairy compared to the Western population. So the cutoff value is proposed to be 6 by the Dermatology Association. So this modified Ferryman-Galway score also can be, it can vary depending on the different races. Now, again, coming to the most important point of today's talk is, why is hirsutism relevant? Why are we spending so much time talking about it? Because it is one of the most prevalent health problems in women of reproductive age that can significantly and negatively impact the quality of life. It is associated with body image issues, anxiety and depression, low self-esteem, Women spend considerable time on the management of their facial hair. The study found out that two-thirds reported continuously checking in the mirrors and touching the hair. 40% felt uncomfortable in social situations. High levels of emotional distress and psychological morbidity were detected. There was depression, there was anxiety, and low self-esteem and low and the attractiveness reduced even by the partner. It was pointed out. So even their sex life also got affected because of the so much of unwanted hair on the body. Although the overall quality of life was good, scores were low in social and relationship domains. So apart from that, hirsutism, as I told you, because it is most commonly caused by PCOS, there can be significant metabolic consequences like dyslipidemia, insulin resistance, diabetes, and hypertension. And very rapid onset within weeks. If there is a very fast growth of hair, then we need to find out other virilizing syndromes, even though they are rare, we need to be aware of that. Now, this is a table which will give us different causes of hirsutism and what is the prevalence in the general population and how do we go about diagnosis. This is a little busy slide, but then it is compiled very well so that we get a picture about what is the prevalence and what are the different tests we need to do and what is the other complications associated we can make out. So the commonest is a PCOS. Almost 10 to 20% of women have PCOS, and we all know how to diagnose PCOS by menstrual history, ultrasound, and hormonal tests. And second commonest is idiopathic hyperandrogenism. Here only the testosterone levels are increased, whereas the cycles are regular and ovaries are normal on ultrasound. And next, non-classical congenital adrenal hyperplasia, 2 to 4%. Again, the prevalence is 1 in 200, not very uncommon. This has got a mild hirsutism, early onset and premature adrenarche, and we need to do all these blood tests. And idiopathic hirsutism, here the androgen levels are also normal, ovaries are also normal, regular periods, and androgen secreting tumor very, very rarely noticed. Now, how do we evaluate a patient with hirsutism? A woman who walks into our clinic and she says that she's got unwanted hair on the body. We need to ask about the age of onset, when did that start, what is the rate of onset of symptoms, whether there is any associated menstrual irregularity, any signs or symptoms of virilization, loss of breast tissue, loss of normal female body contour, and increased libido, and history of weight gain or diabetes. And we have to ask about different medicines which can cause unwanted hair or hypertrichosis, as I mentioned before. And also we should ask about a family history of hirsutism and also family history of PCOS. Once we elicit all this history, we need to examine the patient. We do a complete general physical and systemic examination. We need to palpate the abdomen to see if there is any ovarian masses. We need to do the, as I told you, modified Ferryman-Galway for hirsutism severity assessment. Look also for acne, alopecia, and oily skin. Measure her body mass index, waist to hip ratio, and also in very severe cases, clitoromegaly also can be documented. As I told you, what are the different differential diagnoses? The virilization suggests that there is a androgen secreting tumor, very rare. There can be a rapid growth of unwanted hair. All these features of virilization will be there. And then these women, if we do the testosterone levels, usually it is more than 200 nanogram levels. The second, there is a third commonest is a congenital adrenal hyperplasia. Again, this 2% of women are affected by it. That is late onset, non-classical. As I told you, we need to do hormonal levels, that is 17 alpha hydroxyprogesterone levels to confirm the same. Cushing's syndrome is again a rare, but then it is an important cause of androgen excess, and hirsutism is present in almost 80% of women with Cushing's syndrome. Rapid central weight gain, moon phase, central obesity, striae, hyperandrogenemia, apart from the diabetes and the hypertension we need to measure. Also, we need to ask about the history of taking exogenous androgens, that is injection of androgens or androgen-like activity, like in athletes and anabolic steroids, men and women, both of them can have this problem, even for cosmetic purposes. And to increase the libido, some women take steroids, anabolic steroids. That also can cause hirsutism. Now, once the patient has come to us, and then we have looked at we have taken a good history, we have examined her, and at the same time, we also, when she is talking, we need to ask about how much she is affected by it. That is the most important thing is how much she is upset about the hirsutism. So we need to, if she is too much upset and if she starts crying and if she is depressed and low self-esteem, psychological counseling also becomes a very important part of management of hirsutism. Now, what is a lab investigation? So to establish the hyperandrogenemia, we need to do the total testosterone, and if the facilities are available, free testosterone and sex hormone binding globules, full androgen profile. And DHEAs we do only when the adrenal cause is suspected, that is in adrenal tumors. Very rarely this happens. And to look for the etiology of hirsutism, that is PCOS, then you do all the other tests like menstrual irregularity, and then luteal phase progesterone, and then prolactin test, thyroid test, 17 alpha hydroxyprogesterone levels, abdomen pelvis ultrasound we do to rule out two conditions, that is PCOS and androgen secreting tumors. And if we are suspecting tumors, we need to do a CT or a MRI of the abdomen. And once we confirm, okay, or once we suspect that this woman with hirsutism could be having a PCOS, then we need to do the anthropometric measurements, and we need to do the metabolic profile, lipid profile, glucose challenge, and blood pressure estimation. So typically these are some of the blood tests, as I told you, we do in the evaluation of hirsutism. Now, how do we manage hirsutism? Again, management is very clinically important. Two important approaches. One is to reduce the androgen secretion or androgen action, that is a pharmacotherapy, that is one thing. Second, at the same time, we need to address the removal of the terminal hair which is already present using cosmetic procedures. Now, suppose there is a woman sitting with hirsutism MFG score of moderate or severe, and I start the medications that will act on the new hair which is coming up. Whatever existing is there has to be permanently removed using cosmetic procedures. The goal of management is to reduce hirsutism, treat the associated reproductive complaints, screen and prevent metabolic consequences, and treat the cause of hirsutism. Now, what are the key principles in treatment of hirsutism? Now, hirsutism needs chronic treatment. It does not go away in 6 weeks or 3 months or 6 months. Patients' concern and expectations have to be recorded. Effect of medications are not immediate, may take a few months to be appreciated, and treatment has to be monitored on regular basis. So, which are the different cosmetic measures we use to treat? This is what as I told you, most of the women with hirsutism, they go to the dermatologist. That is, the dermatologist will address all this and then send the patient to us to check whether they have PCOS, because that is the commonest cause of hirsutism. Now, these are some of the temporary methods like shaving, plucking, waxing, chemical depilatory agents. And permanent method is laser, which is the most commonly used and most popularly used. Before more laser was electrolysis, which was used commonly that time. Okay, now these are the various indications: mild and moderate and severe. Always better to go for laser along with the pharmacotherapy. And these are some of the advantages and the disadvantages of these cosmetic issues. This is mainly addressed by the dermatologist. A few words about laser therapy for hirsutism. It has gained a lot of popularity in the past 2 decades and can achieve permanent reduction of hair reduction, but not completely removed. Okay, they work on the principle of selective photothermolysis, whereas the laser energy specifically destroys the melanin. Now, laser energy acts only on the anagen hair follicles, so multiple treatment settings have to be required, and it is, as I told you, it has got expensive, and not everyone can afford the laser therapy. And laser hair removal also is used for idiopathic hirsutism, even with the normal androgen levels, because if the androgen levels are normal, we can't give anti-androgen, so laser hair removal also is suitable there. Now, come to the pharmacotherapy of hirsutism. Now, there are three main pharmacotherapies. One is the commonest use the combined oral contraceptive pills, and if they are not effective, then we use the anti-androgen medications. Now, there are this topical cream called eflornithine cream. Again, this acts locally. It is an irreversible inhibitor of ornithine decarboxylase, which will affect the regulation of the cell growth and differentiation within the hair follicle. And in mild, it can be used alone, but moderate to severe, maybe you'll have to combine with the COCs. Now, COCs, how do they act? Now, we know it acts at the pituitary level, and then it suppresses, and then it increases the sex hormone binding globulin levels, which will reduce the circulating testosterone levels. Along with anti-androgens, if it is given, if it is not effective alone. So effective improvement is seen almost in 60 to 100% cases. Also, additionally, it regularizes the menstrual cycle and then risk of endometrial hyperplasia. But as usual, the complications of and the contraindications of COCs we need to bear in mind before we prescribe. Now, before starting any medication for hirsutism, women with hirsutism as PCOS is the commonest cause, diet and exercise should be advised to all women with PCOS. For all the obese women, weight loss as a therapy could be advised. And upper body obesity has been associated with reduced sex hormone binding globulin. So losing weight actually helps in pharmacotherapy of hirsutism. As I told you, eflornithine, it is locally advised. It's a very potent cream, but then it is only for mild. Maybe along with laser, gradual improvement can be seen in 6 to 8 weeks. It can be used along with laser treatments or with COCs in the management of hirsutism. Now, COC, combined oral contraceptive pills, even though the anti-androgen pills, that is the cyproterone acetate or the drospirenone or the dinogest, are more attractive combinations of COCs, even all the COCs, any COC is equally effective because it acts on 2 levels. It will act on the suppression of GnRH, and also it reduces the LH, and also it increases sex hormone binding globulin. So combined oral pills, any combination is effective in reducing the hirsutism, but particularly if they are having the anti-androgen component like cyproterone or drospirenone or dinogest, definitely more effective. But then these 3 components could be associated with a little more thrombogenic. So we need to be mindful about the different contraindications and choose the COCs wisely in the management of hirsutism. Minimum of 6 months to 1 year we need to give. Obviously the once the woman is taking, it will reduce, and once the woman stops the pills, it may come back. But then meanwhile, lifestyle modification and weight loss also can control the hirsutism. So that is why treating hirsutism can be frustrating both for the doctor and the patient. Anti-androgen, they are the group of medications which block the androgen receptors and also which reduce the 5-alpha reductase enzyme. So therefore, the most active or the most potent testosterone is not, it is inhibited. So that is how it acts. And now because they inhibit the androgen, they are contraindicated during pregnancy, because if the woman is carrying a female baby in the womb, it can virilize the baby. So additional contraceptives have to be given. And then for optimal results, at least for 2 years, we need to give, and this is given when the COCs and the laser therapy are not very effective, or when the patient is not yet happy with the results with COCs. Then we'll have to explain that she should not get pregnant for next 1 or 2 years and then start anti-androgen. Almost around 20% reduction in the Ferriman-Galway score is observed when anti-androgen is given. A new topical anti-androgen called fluridil is being developed, so maybe yet to release in India. So now these are the different anti-androgen components, and how do they act, and what are the dosage. And these are the obviously anti-androgen. Once we give, the libido becomes low and depression could be there. And then increased liver toxicity is observed in cyproterone acetate. That is one of the reasons why it is not being used routinely even in the management of PCOS. So it is, so once the woman comes, so we have diagnosed hirsutism, so done the scoring of the hirsutism, and then done various blood tests to confirm the hyperandrogenemia, and maybe if we are suspecting PCOS, which we should, all of us should suspect PCOS. So we have done all the workup for PCOS, we have started local treatment, we have given hormonal treatment, we have told her to do lifestyle intervention and reduce weight. Along with that, it is very important to follow up this patient regularly. It is crucial to highlight the improvements due to therapy. It will come, the improvement will come slow, and also it will last, but then it can come back once the treatment is started. So that is why lifestyle modification and weight loss, persistent weight loss, is very important. The assessment of treatment efficacy is mostly clinical, so it has to be an objective. So every time they come, we repeat the MFG score, and the patient also feels good, and even also we feel good that it is effective. And every 6 months we need to assess the effects of the drug treatment, also look for any possible side effects of this medication. And change in drug treatment is advised only if the assessed clinical response is not good, even after 1 year. Okay, so these are some of the follow-up protocols we need to use. And key points of today's talk is hirsutism is a common disorder affecting women during the reproductive years. Degree of hirsutism does not correlate with the level of androgens. Hirsutism can cause significant impact on the mental health of the women. The occurrence of metabolic disorders and cardiovascular risk markers in women with hirsutism correlates with the severity of hyperandrogenemia. Apart from the treatment of hirsutism, associated complications also have to be treated. Hirsutism needs chronic treatment, mostly never cured. The same group, Dr. Parag Binewala sir and Dr. Chaitanya sir and Rakhi Singh, we did from the endocrine committee of FOGSI, we have done an algorithm for clinical evaluation and management of hirsutism. So this algorithm says any female who complains of excess unwanted body hair. So we need to check once the patient comes to us, we need to do a clinical examination, do the scoring. If it is generalized, then it could be hypertrichosis, or if it is male pattern distribution, then you evaluate. So first we are going to ask if she is taking any of these medications like phenothiazines, danazol, exogenous androgen and topical androgen use, valproate, phenytoin. So we're going to ask if she is taking any medications, then you consider stopping or changing the medication. If she is not taking any of these medications, look for clinical or biochemical signs of hyperandrogenemia and virilization. So we are going to we're going to ask, what was the onset of these symptoms? Yes, there was the other clinical signs like hair loss and acne. And then if it is slow in onset, then we need to go to the period history. So if the periods, if they are irregular, then we have to think about PCOD. If it is regular cycles, that is when we need to think about a idiopathic hyperandrogenism or a non-classical congenital adrenal hyperplasia. Of course, to rule out a PCOD, we need to do a scan. So if the scan is normal and if the periods are regular, only androgen excess is there, then we need to be thinking about idiopathic hyperandrogenemia. And in case if the patient does not have any other signs of hyperandrogenemia, only unwanted hair, then it is called idiopathic hirsutism. So all of you can please download this poster. It's a very beautiful, well thought of poster, very concise with lot of references. So this clinical evaluation and management of hirsutism by FOGSI endocrine committee, 3 years back we released it. And these are the management protocol or management algorithm. Lifestyle modification for obese and PCOS women. First line therapy is pharmacotherapy, and which are the times which is contraindicated. Second line is anti-androgen, and third line is combination of these two medications. Okay, so that is how I summarize the um, management of evaluation and management of hirsutism in women. Thank you.
Thank you, ma'am. Can I request our chairpersons to give their comments?
Yeah. I'm Dr. Nutan Agrawal. Actually, I could join little late. There were some problems in the internet. It was a very nice and informative lecture because I could hear it, but I could not get the slides initially. She's very right that hirsutism, of course, we have to 80% patients, it is because of PCOS. And these are the patients which can be treated with the anti-androgen treatment and the OC pills. But other causes, if it's not a terminal hair and all, of course, it's difficult to treat. But the only question comes that whether we need to do the follow-up with testosterone. So I think it's clear the testosterone, because it's not very well correlated to the levels also. So we don't require to do the testosterone level follow-up. But usually in the practice, when we do the testosterone, we want to see whether it is going correcting or not. So we do the follow-up 6 months, 1 year, whether the testosterone level have come normal or not. But otherwise, we say for the hirsutism per se, we don't do the follow-up with that. Now the question comes whether we have to give the insulin sensitizer or not. Because otherwise in the guidelines, they are not mentioning about the insulin sensitizer. But I have seen in my practice that when we combine with metformin, even alone metformin, I have done the research on metformin and myonisitol both the first time in India. And I have found that both drugs, they work on the hirsutism, although not so well as the other anti-androgenic treatment. So if you are not giving OC pills due to any reason initially or something, we can also try metformin, or we can combine OC pills with metformin. That also increases the results with something. Then the local application is also effective. In my practice, I've seen the local applications, although we cannot give in those patients who are trying to conceive. Even the local therapy is also contraindicated for these patients. So one has to be very careful. I have seen patients which are applying the drug even when they have conceived, thinking that that is a local treatment. So that also causes the malformation. So we should not give the local treatment in the PCOS cases if they are trying to conceive. That is important. So the only thing that OC pills, low dose or high dose, I mean the 20 or the 30, 35. So initially, actually, they say that probably 20 may not work so well, but we usually recommend to give 20. And you can give all the drosperinone or desogestrel also combination is effective. Drosperinone, the only question comes because of the DVT and also initially you have to be more careful with these drugs. Otherwise, we have to give COC and then can combine with, if not effective, with the anti. as far as finasteride and flutamide, we have given finasteride and it is effective drug. Some patients where we cannot give spironolactone, some problems, or we want to combine even two drugs. We have combined sometimes spironolactone with flut. But flutamide usually we don't prefer because of the hepatotoxicity. So this is really the main thing is that you have to explain the patient. It will take at least six months to 1 year before they go for the laser therapy, because it takes to stop the new growth. We have to give a treatment for 6 months to 1 year, and then patient can go for the laser treatment after that.
Very right, madam, because as you told, in PCOS, insulin resistance and hyperandrogenemia are both bidirectional or interlinked. So as madam says, maybe in women who are desiring pregnancy but who are in whom we can't give anti-androgen also, we could, along with the lifestyle modifications, maybe giving metformin and inacetones definitely can help them reduce the weight and increase the HSPG, and then maybe.
I have seen one thing in my practice, that myonisotol, because I have done a large work on myonisotol. About 2-3% of patients, they have initial flare-up of the acne. But hirsutism as such, it's not so. Hirsutism treatment, I think the metformin is better than the myonisotol for hirsutism also.
Thank you, ma'am. Dr. Kavita, ma'am.
Chandrika, it was very enlightening lecture. I think you have very nicely explained the evaluation and treatment of hirsutism. And most of the patients who come to us with hirsutism are in the adolescent group of age, and they're always having some psychological aspect. So these patients, I think they require a lot of counseling regarding the patients that they should have, because it is a long-term treatment. The effects will not be there soon. So the psychological aspect also needs to be looked after in these patients. And very rightly said that how what Dr. Nutan also was explaining about metformin. So what evidence says about metformin is it will help in the metabolic abnormalities, as you mentioned, hyperinsulinemia and insulin resistance. But direct effect on hirsutism is lacking, according to the evidence. So only metformin may not help as much. And I had this thing about postmenopausal hirsutism also. Some of these ladies do come in the menopausal transition, and they have all these androgen excess symptoms and signs like alopecia and increased facial hair also. So what are your comments on postmenopausal hirsutism?
Madam, postmenopausal hirsutism is the pathology or the pathophysiology is not directly linked to hyperandrogenemia, because in menopause, both the estrogen and the progesterone and also the ovarian secretion of the androgens drop down. It's more of a peripheral fat conversion into one of these hormones could be causing that, even though it is distressing. So in this age group, if they are conscious about it, maybe local therapies would help. And maybe if they suddenly develop a lot of hair, then we need to be mindful about the ovarian tumors or the adrenal tumors, even though they are rare, that is rapid virilizing tumors in the postmenopausal age group. So if once we need to do an abdomen pelvic ultrasound, and we need to ask if they had any history of PCOS. Sometimes women with PCOS will have a late menopause and persisting high androgens. And also to do the testosterone levels, if it is very high, like more than 200, then we need to be mindful about the tumors. If it is not there, if everything is normal, maybe local cosmetic therapies should be good along with the lifestyle modifications.
So I think in the menopausal transition, there is a relative androgen excess because of the estrogen going down. So that presents as hirsutism and increased facial hair and all.
Yes.
So I would like to tell that some of our patients who come to us, even though PCOS is very common as a cause of hirsutism, but we do get patients who have virilizing symptoms and signs. So always look for clitoromegaly and look at the clitoral index and other signs of virilization, and then only proceed. Yes. So I think you have answered most of our queries which we had regarding hirsutism. I'm sure all the audience must have really felt enlightened after your lecture. Thank you, Dr. Chandrika.
Thank you, madam. Thank you so much.
Actually, virilization is very, very rare in the PCOS patients. So if we find a virilization, we have to check for the tumors, and We have to look for the, if it is a young patient, then of course there can be the partial androgen and all if they are associated with amenorrhea. Otherwise, we have to check for, sometimes the tumors are very small. So the proper techniques are required, arterialization and all, to assess the tumors.
Yes, madam.
Fantastic discussion, and Dr. Chandrika, you have really made a very difficult and complex topic, simple, and the crisp messages which you gave were very important. And you also highlighted that usually these patients, they land up in skin OPD, and once they get all the cosmetic things done, then they get referral to gynecology. This trend we have to revisit, we have to recheck, and as our chairpersons have also added that in many patients we have to see for ovarian tumors or any other causes of hyperandrogenism. So it's very important that our patients get acquainted or well aware that these referrals to gynecopedy is very important. A complete checkup, and then coming to a conclusion that then they need only the cosmetic therapies, and sometimes they need the additional medicines also. So this overview is very important for the understanding of all the consultants and the students, and very well given messages. Thank you, Chairperson, for your inputs. They were very valid and very important. So overall, it was a very good academic session, and we thank you all.
Thank you so much.
Thank you, Dr. Vishal.
Thank you, ma'am. I would now like to hand over to my colleague, Dr. Mansi Sharma, to conduct the quiz.
Like to first thank our chairpersons and speaker, ma'am. It was a wonderful session. We came to learn a lot of things, and it was very concise and knowledgeable session. Thank you so much, ma'am. I would now request Trusha to share the
Yes, ma'am.
QR code for the quiz. I would please request the chairperson as well as Dr. Chandrika madam to join us for the quiz. We have a short quiz for the same topic. The quiz, we have 5 rounds with 5 questions per round. We will be starting shortly. The QR code, just share the QR code first. We will also be sharing the link in the chat box. You can also join through the link. Can we also have the link in the chat box, please?
Yes, ma'am.
I will request everyone to join us for the quiz. The link is shared in the chat box. You can either join through the QR code or through the link. The quiz is on the topic hirsutism. As usual, the first round is a visual round. Each round has 5 questions. I think we have 5 participants so far. We will be waiting for 1 minute more and then we'll be starting. We have scoreboard which is there after every round, and the ultimate scorecard after the final 5th round. Ma'am, almost all of the questions were there in your slide. I would request
I hope I'll get them right.
I would
That's the
request
problem.
everyone. I would request everyone to please join us for the quiz. If anybody has difficulty in joining the quiz, do let us know. Should we start?
Yes, Mansi, please start.
Yes. Okay, we will be starting. So we have the first question of the round. Yes. Which of the following sites is not included in the modified Ferryman-Galvin scoring, whether it is upper lip, whether it is lower abdomen, whether it is forearm, or whether it is chin? You have the modified scoring there. So which of these site is not included in the modified scoring? not the original 11, the modified scoring. We have 2 seconds remaining. Time is up. Yes, we have 3 answers correct. The forearm is not included in the modified scoring. Can we have the score after the, can we have the next question, please? Okay, the second question for this round is, a 32-year-old woman presents with rapid onset hirsutism. Which lab parameters matches with the CT finding? So there is a query suprarenal mass. I'm giving you a hint. Increased DHEAS more than 700, whether it is increased LH-FSH ratio, whether it is increased 17-hydroxyprogesterone, or whether it is increased prolactin. That is a CT finding. Yeah, 6 of you are correct. That is increased DHEAS. It is an adrenal mass, most probably an adrenal tumor. Can we have the next question, please? Okay, which enzyme is primarily responsible for the conversion of vellus hair to terminal hair in androgen sensitive areas? Whether it is aromatase, whether it is 5-alpha reductase, whether it is 17-beta hydroxysteroid dehydrogenase, or whether it is 11-beta hydroxylase. So you have to give the correct answer. So you can join the quiz as well and write the answers, please. Okay, so 5 of you are correct. The correct answer is 5-alpha reductase. Can we have the next question, please? Okay, so which test best confirms or most probably confirms the diagnosis which is suggested by the image, whether it is 1 milligram overnight dexamethasone suppression test, whether it is ACTH stimulation test, whether it is serum prolactin, whether it is LH-FSH ratio. There is an image there. There is one which is typical facies, which you can see. There is also abdominal purple striae, central obesity. Okay. Yes, it is 1 milligram overnight dexamethasone suppression test or 24-hour cortisol test. Can I have the next question? Cushing syndrome was the answer. The next question, laser hair reduction works best on hair in which phase of the hair cycle? Whether it is early catagen, whether it is late telogen, whether it is early anagen, or whether it is exogen. This was also covered in Madam's slide right now. On which phase of the hair cycle does the laser hair reduction works? Sir, you can join the quiz and give the answer through the quiz as well. You can join through the QR code or through the chat box. Yes, 2 of you are correct. The correct answer is early anagen. Okay. So, do we have the scoreboard after this round? Dr. Jagriti, followed by Dr. Maheshwari, Kavita, Anuradha. Dr. Jagriti has the highest streak of all 5 correct answer. So, very good. Can we have the next round, please? Okay, so the questions for this round are, hair follicle development begins during which embryologic week? Whether it is 4 to 6 weeks, whether it is 8 to 10 weeks, whether it is 12 to 14 weeks, or 20 to 22 weeks. We are talking about the hair follicle development, not the lanugo hair. All the questions have been taken either from Sperov or Novak, all the standard books. Okay. Some confusion. The hair placard development starts from the 8 to 10 weeks. So the correct answer for this is 8 to 10 weeks. If we are talking about the lanugo, that will be the 20 to 22 weeks. Can we have the next question, please? Which ovarian morphology on USG is most clearly correlated with hyperandrogenism in PCOS? Whether it is more than 12 follicle per ovary, whether it is increased ovarian volume more than 10 centimeter cube, whether it is peripheral distribution of the follicles, or whether it is increased stromal ecogenicity. For PCOS, which ovarian morphology more correlates with the hyperandrogenism? Okay, yes, 5 of you are correct. It is increased stromal ecogenicity as it corresponds to the thecal hyperplasia, hence increased androgen production. The correct answer is D. Which ethnic group tends to have the highest baseline Ferriman-Galway scores despite normal androgen levels, whether it is East Asian, whether it is Mediterranean, whether it is Scandinavian, whether it is Sub-Saharan African? In this, there can be slight confusion, but I have taken one which is more commonly taken everywhere. So, okay. Okay. So I do not know why there is nobody has tick marked the Mediterranean group, because a lot of books, including Novak as well as Sferov, has given the Mediterranean as the highest baseline scores. Sub-Saharan have been included in that, but a lot of books have taken only as Mediterranean. So I have taken it as the Mediterranean group. East Asian is not correct, definitely. Can we have the next question, please? Which of the following explains why postmenopausal women often develop mild hirsutism? Whether it is decreased adrenal androgen production, whether it is increased ovarian estrogen secretion, whether it is increased peripheral conversion of androstenedione to testosterone, or whether increased sex hormone binding globulin levels. We have just discussed this. Madam had just given the answer for this as well. Yes, it is increased peripheral conversion of androstenedione to testosterone, which is the correct answer. A 24-year-old East Asian woman present with minimal terminal hair on the chin and upper lip, but total MFG is 4. Serum testosterone is mildly elevated, which is the most appropriate interpretation. Normal variant for race, significant hyperandrogenemia despite low score, pseudo-Cushing syndrome, overestimation due to the skin type. For the East Asian or Chinese Han, MFG is 4 here. Again, see, for the East Asian or Chinese Han, the 2 to 3 is taken as the limit for MFG, for more than which is taken as hirsutism. So the correct answer is B, significant hyperandrogenemia despite low score. There is a racial variation when we take the MFG. So it is not universal more than 8 leading to hirsutism. Can we have the next question, please? Okay, so we have the leaderboard score almost same with Jagriti, followed by Kavita, followed by Anuradha, followed by Dr. Maheshwari, with Dr. Jagriti having the longest streak of more than 7 correct answers. We move on to the round 3. A 30-year-old female with Ferriman-Galway score of 9 but normal serum testosterone and DHA level most likely has PCOS, idiopathic hirsutism, congenital adrenal hyperplasia, adrenal tumors. All her androgen levels are absolutely normal. Her androgen levels are normal. She's only having hirsutism. Absolutely normal androgen levels. Yes, correct. It is idiopathic hirsutism with normal androgen levels and only hirsutism. So the correct answer is idiopathic hirsutism. Can we have the next question, please? A 23-year-old female with gradual onset of hirsutism, acne, oligomenorrhea, chronic anovulation for 2 years. Lab parameters are total testosterone of 120, DHEAS mildly elevated 250, LH-FSH ratio is 3:1, 17-hydroxyprogesterone normal. What is the most likely diagnosis? Whether it is PCOS, whether it is adrenal carcinoma, non-classic CAH, or whether it is idiopathic hirsutism. Yes, 5 of you are correct. It is most likely PCOS. A 19-year-old female with hirsutism since adolescence. Lab parameters 17-hydroxyprogesterone is high, 560, DHAs are mildly raised, testosterone are mildly raised. A confirmatory test would be, or the next step would be, you do a LH-FSH ratio, or you do a ACTH stimulation test, or you do a dexamethasone suppression test, or you do a GnRH stimulation test. When you find a 17-hydroxyprogesterone of 560, what you do? Yes, you most probably do a ACTH stimulation test. Can we have the next question, please? A 27-year-old female with mild hirsutism, normal total testosterone, but low sex hormone binding globulin. Which additional test would confirm increased free androgen index? Whether it is free testosterone by equilibrium dialysis, whether it is DHEAS, LH-FSH, or cortisol. What test, though it is not practically available, but is available in research settings, and if it's available, you should do it. Expensive test, we have covered this. 3 of you are correct. It is free testosterone by equilibrium dialysis. Can I have the next question, please? A 20-year-old female with rapidly progressive hirsutism, deepened voice, clitoromegaly, lab testosterone, total testosterone is 380, DHEAS is normal. What is the next best step? ACTH stimulation test, adrenal CT scan, pelvic USG for ovarian imaging, or dexamethasone suppression test? The testosterone is on the higher side. DHEAS is normal. She's virilization, almost rapidly progressive hirsutism, deepened voice, clitoromegaly. What will you like to see? Okay. There is a slight confusion. Adrenal CT, most probably to rule out an adrenal tumor, but because the DHEAS level is normal, it is most likely an ovarian carcinoma, which is an androgen secreting carcinoma, rather than being an adrenal tumor. So we would first like to do an ovarian imaging. So the most likely next best step would be an ovarian imaging rather than an adrenal CT. So the better answer would have been a C rather than a B. Can we have the scoreboard after this one? Okay. So the scoreboard, there is slight changes with Jagrati maintaining her first position with all the right answers till now, followed by Kavita, PK, Anuradha. We do have a lot of confusing questions in the MCQ format to make it a little bit more interesting. Can we move on to the round 4, please? Okay. The first question for this round is 28-year-old female with hirsutism and PCOS is started on combined OCPs. What is the primary mechanism by which OCPs improve hirsutism, whether it is increasing sex hormone binding globulin and decreasing free testosterone, whether it is stimulating adrenal androgen synthesis, or it is increasing LH secretion or decreasing hepatic metabolism or DHT? So what is the primary mechanism? We have covered this. So 5 of you are correct. It is increasing sex hormone binding globulin and decreasing free testosterone level. That is the primary mechanism. Move on to the next question, please. Which of the following anti-androgens is a non-steroidal competitive inhibitor of androgen receptor commonly used in prostate cancer but occasionally used for hirsutism, whether it is flutamide, whether it is spironolactone, whether it is finasteride or cyproterone acetate? The side effect is hepatotoxicity, not commonly used so much right now. Very straightforward answer. Three of you are correct. Flutamide, anti-androgen, non-steroidal competitive inhibitor. Can we have the next question, please? Finasteride is a 5-alpha reductase inhibitor. How long should a trial of pharmacotherapy for hirsutism last before changing doses? 2 months, 4 months, 6 months, and 8 months. I just saw the madam's slide. There was 1 year. What I could find out, ma'am, was slightly different. So this may be.
Yeah,
Yes.
even though it is 1 year we need to take, but at least 6 months minimum we need to wait. So that
Minimum,
is how
yes.
6 months makes sense. Pa.
So, can we have the next question, please? Hair removal using electrolysis is recommended for women with which hair color? Brown, blonde, black, auburn. This is using electrolysis. We are not using photoepilation here. This is electrolysis. I'm giving you a hint. It is electrolysis. Photoepilation typically is used for women with certain hair type. Okay. Okay, 2 of you are correct. Electrolysis is used for a very short treatment areas, and it is not dependent on the pigmentation of the hair. When we use photoepilation, it is used for the pigmented hair. So brown, black, auburn, we use for a long-term treatment interval, and photoepilation is used. When we are using electrolysis, it is for women with white hair or blonde hair and for a short treatment area. Can I have the next question, please? Topical eflornithine acts in hirsutism by blocking androgen receptors, inhibiting ornithine D carboxylase in hair follicle, blocking DHT synthesis, or decreasing sex hormone binding globulin levels. Yes, we have 5 of you are correct. The correct answer is B, inhibiting ornithine decarboxylase in the hair follicle. With this, we move on to the last round. Can we have the leaderboard before this? The scoreboard, there is only slight change with PK moving to the second position and Kavita moving to the third. Dr. Jagrit is maintaining her first position. We move on to the last round for the quiz. Okay, the first question for this round is, it's a mixed background. So dermal papilla critical for androgen dependent hair growth, as in hirsutism. It originates from epidermal ectoderm, neural crest cell, mesenchymal dermis, or surface ectoderm. Okay. Because it is a combination from ectoderm, it goes to inside. The correct answer which I could find is mesenchymal dermis. It goes into the ectoderm, form the papilla and placard. The mesenchymal dermis is the correct answer. No? A patient with PCOS has severe hirsutism. She started on spironolactone 100 milligram per day. What should be monitored during therapy? Whether it is LFT and prolactin, serum potassium and renal function, fasting glucose, or bone density. What do we normally monitor if a patient is on spironolactone for a longer interval of time? Yes, serum potassium and renal function. Very straightforward answer. Can we move on to the next question, please? In laser hair removal, why are multiple sessions required? To increase the melanin concentration, to target hair in different anagen phases, because laser induces new follicle formation, or to suppress the sebaceous gland function. Yes, to target the hair in different anagen phases, we require multiple settings for the removal. The correct answer is B. Which of the following hormones is antagonist to androgenic hair stimulation? Whether it is growth hormone, whether it is prolactin, whether it is estrogen, whether it is cortisol. Which of this is typically in the follicle works as an antagonist to the androgenic hair stimulation? Yes, 4 of you are correct. The correct answer is estrogen. Can we move on to the last question for this round? Which androgen has the least effect on the hair follicle androgen receptor stimulation, or in other words, a very weak potent androgen? Testosterone, dihydrotestosterone, androstenedione, or DHEAS? Which of these is a weak androgen? I have made it very simplified. Oh, okay. This question is directly taken from Spiroff. There is a line there where the androgenic effect on the hair follicle stimulation is given with this. The correct answer is D, DHEAS. It has the least effect on the hair follicle androgen receptor stimulation. It is DHT followed by T followed by A followed by DHEAS. So can I have the leaderboard score? Okay, so we have Dr. Jagriti in the first position, followed by PK, followed by Kavita, followed by Anuradha. I am not able to see the fifth position. Just give me one. So congratulations to all the winners. And thank you, ma'am, Dr. Chandrika, ma'am, Dr. Kavita, for joining us for the quiz.
Thank
Doc-
you. Lovely. You actually
Dr.
threw
Nutan
threw
also.
some googlies also. Okay. Even I got some 2-3 wrong. But of
Ma'am,
studying so much. But that happens. I mean, that is the beauty of endocrine. It's not an easy subject. It is a challenging subject. So how much ever read, we can always learn something. So I could learn a lot from your questions. So congrats. You made a very good, very interesting set of questions, I should say.
Thank you, ma'am. Thank you, ma'am.
Very well conducted, Mansi. The quiz, very interesting.
Thank you, ma'am.
Yeah, nice.
Thank you to all the chairpersons, Dr. Nutan, Dr. Kavita ma'am, Dr. Chandrika ma'am for joining us today, and all the participants and all the quiz winners. We will finish this session with this. I really thank all of you to join us today.
Thank you, sir.
Thank you.
I would also like to thank our IT team for all the support they give us. I would also like to thank Dr. Parag Biniwale, Dr. Vishali Madam, Dr. Chaitanya Ganpule sir, and the entire endocrine team. I think Madam is not there, Vishali ma'am, but